Thank you for inviting me to speak today about what's new in pediatric atopic dermatitis. I'm Amy Paller from Northwestern University in Chicago, and these are my disclosures. Atopic dermatitis is primarily a pediatric problem. We know that the prevalence in children is 10 to 18% versus about 7% in adults. In fact, about 60% present before 1 year of age and 85% by 5 years old. We know that many children who have atopic dermatitis have what seems like clearance after the first few years, and that the onset can be at any time throughout life, even in those who are greater than 60 years of age. But of those children, about 2/3 have mild disease and 1/3 have moderate to severe atopic dermatitis. So very quickly, what's new with topical therapy for pediatric atopic dermatitis? Well, of course, topical steroids remain the mainstay of therapy, but non-steroidal topicals are increasingly available. And I want to give a shout out to the topical calcineurin inhibitors, which are now more than 20 years since their availability. And in fact, several studies have now shown their safety, and it was the Joel study that came out in 2018, and now the new Apple study, which that should be 2021 when it came out, that have led to the reversal in Canada of the boxed warning that's been there for so many years now for tacrolimus and also for pimecrolimus. And I'm hopeful that the boxed warning will finally disappear at some point for this group of topical calcineurin inhibitors in the United States. Crisaborole, of course, is the newest one besides the JAK inhibitor. And crisaborole is now FDA approved for those 3 months of age and above with mild to moderate atopic dermatitis. Our experience in real-world studies has suggested a higher rate of burning and stinging than what we found in the original clinical trials, and that has been rate limiting for its use. Topical ruxolitinib cream just came out in the last several months. As you know, this is a JAK1/2 selective that is now FDA approved for mild to moderate atopic dermatitis in those who are at least 12 years of age. But it does carry the class effect boxed warning, even though it's just a topical preparation. And that is a theoretical risk, but nevertheless is one that we need to heed. I remind you of the study itself for this, in which the 1.5% that's currently available was compared with a 0.75% in vehicle in an 8-week trial and then subsequent follow-up. I also remind you that the JAK inhibitors not only get the IL-4, IL-13, but also downstream of the IL-31 receptor, and therefore theoretically can help beyond the IL-4, IL-13 inhibitors in terms of itch. Quickly, these are the results from the topical ruxolitinib trial, specifically in adolescents. And as you can see, there's a clear separation between those on active medication versus placebo, and the 1.5 ruxolitinib doing a bit better than the 0.75. With respect to side effects, really nothing seen. There's actually less burning and stinging with the topical ruxolitinib than its vehicle. And what's important is that all of these studies only took it up to 20% body surface area. In those studies, there was negligible absorption, but of course it can go up if there's greater body surface area on which it's used. So keep that in mind because there is that limitation. I will mention that brepocitinib and delgocitinib creams and ointments are emerging as new topical JAK inhibitors. Delgocitinib now has been available for several years in Japan. A few other emerging topical nonsteroidals, roflumilast is a more potent PDE4 inhibitor than crisaborole, and it looked superior to vehicle in 4-week phase 2 studies, including those that included adolescents, and it's now in trials for mild to severe atopic dermatitis for those 6 years of age and older. It reportedly has less burning and stinging than crisaborole. The first of the TAMAs, the therapeutic aryl hydrocarbon modulating agent, tapinarof, this is an agonist of the aryl hydrocarbon receptor, and it affects a variety of areas that impact atopic dermatitis, including that it actually regulates a protein called artemin, which is an activator of the TRPV1 and the TRPA1 signaling pathways in the dorsal root ganglion, therefore could be helpful with itch. It's been used in adolescents, and the early studies look quite good with no stinging or burning, but some incidents of folliculitis. And finally, we're looking forward to the topical commensal Staphylococcus hominis applied with strong anti-staphylococcal killing, and the preliminary data in adults look promising, but no pediatric data yet. So new therapies, as we talk about systemics, are all pathogenesis-based, and I remind you here about the strong Th2 pathway that's involved in thinking about most of these agents. So we ask the question, what about in children? Are children any different from adults? And we've done skin and blood biomarker analyses to assess changes with different ages. And as you can see here, looking at skin biomarkers, the type 2 and the type 22 immune pathways, or rather the Th2 and the Th22 pathways, are increased in both non-lesional and particularly lesional skin across these various ages. And that suggests that targeting type 2 cytokines should work universally, and to date they do. I will point out that the increases in Th1 seen in many adults with atopic dermatitis are not seen in children. There tends to be a relative deficiency of the Th1 pathway, that there are bimodal increases in Th17 with age, and that there's a progressive reduction in tight junction genes with age. And although reduced even in the very young children, it's not to the level that we see later on. When we look in blood, we can see again the strong influence on the increase in frequency of the IL-13 expressing cells. But I point out that this Th1 or interferon deficiency that we see is seen in the blood, and it may affect handling infections. You can see that in the young children, but even still in adults, there is less of a Th1 propensity in blood. The IL-13 positive T cells are only the CLA positive, CD4 positive ones in the very young children in the first 6 months of life. But over time, we see the IL-13 positive cells expanding to the CLA negative, and then the CD8 positive subsets as well with increasing age. And that may have a relationship with the occurrence of other atopic disorders, remains to be tested. Because we're talking about children, I want to remind about the use of tape strips for painless biomarker measurements. I show you here some of our work with that. There's sufficient stratum corneum material for RNA-seq, proteomics, lipidomics analysis, and others. And markers that are seen in biopsies versus tape strips differ, but the patterns of immune expression are the same. And in fact, it's been shown that tape strips may give a better snapshot of the outer epidermis. So the hope is that these will ultimately be predictors of best management, but we haven't seen that come to fruition quite yet. I do want to remind everybody that we have to have severities of atopic dermatitis in using systemics. And I want to tell you about the increasing use of the measure called IGA times BSA, as well as the atopic dermatitis control tool. This is a study that just came out and complements an earlier study, but has more than 36,000 data points, including more than 5,000 children, that clearly showed that the IGA times BSA, that is its product, correlates very highly with the EASY score. And in fact, in this study was able to show that changes in the IGA across BSA over time very nicely correlate with those of EASY scores in patients who are put on medications. I want to alert you to the AD control tool, a wonderful patient-reported tool. I've given you in purple here at the bottom the website. Please write it down, because this is so easy. It's 6 questions that the patients answer and does very well to tell you about how troubled they are. So we have some wonderful patient-reported outcomes measurements, and this is available in both Spanish and Portuguese. Finally, I want to just remind you about dupilumab in pediatric atopic dermatitis being available now for 12 to 17 and 6 to 11-year-old patients. And as you know, at least by FDA approval, there are some different dosings that come out of these trials, as shown here, with every 4 weeks being recommended now for those under 30 kilograms. The same potential adverse events in adults, particularly injection site reactions and conjunctivitis, and reduction in skin infections as well. What's new is that there's no need for laboratory monitoring. The increase that's seen in eosinophils during the course of the 16 weeks on dupilumab has not been clinically meaningful. And real life experiences that are coming out in pediatric atopic dermatitis do show a few things we need to be aware of. One is this dupilumab associated facial erythema that was originally described in adults. And I was very intrigued by this study coming out of Philadelphia showing that the dupilumab associated facial erythema seen by this group was on the same order of that of injection site reactions, 11.9% of the children on dupilumab, and actually even a little bit more than the conjunctivitis. And in this paper, the majority were female. The mean time into the course was 7 months, and 2 required discontinuation versus none with conjunctivitis requiring discontinuation of the dupilumab. So something to keep an eye on. Also, there was a recent study of 6 children with new onset psoriasis during dupilumab therapy, mean duration 8 months on therapy when this occurred, most cleared with topical therapy and continued the dupilumab, but calling it to your attention because we know that it does shift the immune pattern in the skin in children, and those who may be susceptible to psoriasis, it may allow unmasking. We do now have dupilumab likely to be approved soon for 6 months to 6 years, and as you can see here, as with all of the other studies, distinct percent achieving the clear or almost clear EASI-75 and itch reduction, no new safety signals, and the likely dosing will be 200 milligrams every 4 weeks for the very smallest children, and then again, the 300 milligrams every 4 weeks for under 30 kilograms. Emerging biologics, tralokinumab was just approved for adult use in the United States, and it's also approved in Europe. And as you can see, this is the available data for the 12 to 17-year-olds with tralokinumab, and it does look good. The numbers are a bit less than what we've seen with dupilumab, so may not be quite as effective, but over time seems to keep getting better, and it does represent an alternative. There are no unexpected safety signals, maybe perhaps even a little less conjunctivitis, which may be an advantage. Adolescent trials of lebrikizumab, the other interleukin-13 inhibitor, and nemolizumab, an IL-31 receptor inhibitor, are ongoing. And finally, comments about JAK inhibitors. Only upadacitinib, which is JAK1 selective, is currently FDA approved for adolescents, but abrocitinib, JAK1 selective as well, has shown efficacy and safety in those who are 12 years of age and above, and I suspect it will be approved in the next year. Baricitinib, a JAK1/2 inhibitor, is in adolescent trials, not in the United States, but currently in South America and other sites. What I'll say about this group is that it has a rapid and strong effect on itch, perhaps because of the IL-31 effect. In addition, it is an advantage in that it's an oral agent. Taken once daily rapidly clears if there's a concern and you want to clear it from the system. It should be easy to stop and start, so maybe for patients with seasonal disease or intermittently for flares. And there may be some advantage for children with concurrent alopecia areata or vitiligo. But the reason that many of us are taking a somewhat wait and see attitude is because of safety. Of course, this is a concern for all JAK inhibitors, and it's typically a deciding factor for parents. There will clearly be a black box warning on every one that comes out. It is not first line per its label. Lab monitoring will be required. However, that said, in the studies, the side effects seen were not ones that would generally lead to any discontinuation or concern. Nausea and vomiting predominating with abrocitinib, acne with upadacitinib, headaches in both cases in a small minority of patients. The lab monitoring is for lipids, creatine kinase, and to look at blood counts because they can at least transiently be low. But there has not been a sign for malignancy, thromboembolism, a high risk of infections in atopic dermatitis, or cardiovascular events. What we don't know is that when larger numbers post-approval begin to use these drugs, and over time, if a signal will emerge. So we're all keeping our eye on safety. And with that, I want to thank you for your attention.